Morning, Dr. Egan. How are you?
Good morning, King Sir Nicholas Roy, DMD, MAGD.
Thank you. Thank you. It'd be nice if America had something like knighthood, sir.
Yeah. That would be amazing. Sir Nikolai.
I guess you get the Presidential Medal of Honor would be the equivalent to knighthood. Anyways.
What's the Presidential Medal of Honor in dentistry? That's the real question.
That's a good question.
MAGD? I don't know.
Yeah. Depends on the audience. Anyways, you and I had a pretty cool case that we're going to unpack here. Debriefing is something that you and I have found to be very valuable when airplane pilots go on their mission. Well, I wouldn't say airplane pilots, but military
fighter pilots. They go on sorties, right?
Yeah, military pilots do their sorties. They often consider the debrief more important than the preparation and the brief. So here we're going to debrief a case we did earlier this week, bilateral sinus lift on a patient who ultimately needs some implant retention to get rid of the palate on his denture. So what we'll do first, we'll kind of just assess the pre-op CAT scan and have a discussion about what we needed to do. Can you see the video here?
Yep.
Very good. All right, so maxillary sinuses. The first thing we want to look at, and I don't have all of the CAT scans here, but looking at whether the osteomeatal complex is patent or not. We know that the sinus drains through that infundibulum, which is up here. The CAT scan cut it out. But when we do our assessment of the CAT scans, we want to make sure that we have a pre-op CT that is high enough to capture that entity. Now, we can assume it's draining based on the fact that we don't see a lot in the maxillary sinuses. You know, typically if you see this completely opacified, the patient either has some sort of pathology or chronic sinusitis that is compromising the sinus's ability to drain. We know the cilia in the Schneiderian membrane take mucus, lift it up, and then it drains it into the nasopharynx through the infundibulum, the ostium, or the osteomeatal complex. Those are the three terms used in the ENT world. We have a little bit of sinus inflammation here, but this is not something that requires any attention. Although we could talk about what is a polyp, what's not a polyp, what's thickening, what's not. You and I know why he had this, and it had to do with an impacted wisdom tooth. So any thoughts or questions on assessing the sinuses?
I think one of the most important things to remember is the flatness of the floor of the sinus. You know, really, really narrow sinus, that's going to create a lot of trouble in trying to lift that membrane. So having a nice angle, you know, the literature discusses that extensively.
So the difficulty in lifting
angle
the
of
sinus.
The sinus. Yes.
Yeah. So if this angle right here was like right here, and you had a very narrow sinus, that would be a more difficult sinus to lift.
Yeah.
Yeah. Would it increase the risk of tearing the membrane?
I believe that Pico talks about that in some of the videos I've seen with him.
Sure.
But
yeah, we'll be referring to Michael Picos, the oral surgeon in Florida, who has a wonderful multi-part series you can buy online to learn a lot about this stuff. So if anybody's listening, be happy to share that information. Michael Picos, I think one of the things that he does is he wants to spread the literature into the profession. As an oral surgeon, he knows that he's teaching general dentists doing this stuff, but what he's doing is he's taking concepts in the literature and putting them into the mainstream, and I commend him for that. So assessing the sinus itself would be very important. So the width, yes, you're right, and the fact that the more narrow it is, the more vertical the walls and the less horizontal the floor, the more difficult it is to lift. With that said, it's not a contraindication, it's just a consideration. What about septa? So when we're looking at sinuses, I don't know, between 5 and 15% are going to have some sort of septa. Fortunately, this patient didn't have that. You could call that a form of a septa or septum. But assessing those and knowing where they are is very important. Let's not spend a whole lot of time.
There was something unique on 16 where that infection had been, where the sinus was really tethered tightly to where that infection had been. When we were lifting it, we had a lot of trouble getting it up.
This area here.
Yeah.
Yeah, so he had 2 impacted teeth, 1 in 16. He had seen some oral surgeons over the years that said, let's just leave them. There was decay here. For whatever reason, this slice doesn't show it as well as
the treatment one. You can really see the caries on that, the infection. Actually, when we accessed the site, there was like lots of separation. He had a pretty large abscess that had burrowed its way out.
Yeah, and we had, when I got in there at one point, I could actually see the hole that was created. So after you pulled the tooth out, there was a hole created from the abscess into the sinus floor, not the Schneiderian membrane. The Schneiderian membrane was intact here, but the cortical bone had a perforation from the abscess, and from the window we could actually see inside and see that, which is more just an observation. But the point is, like you said, this was an active infection, and the Schneiderian membrane was responding to that with some inflammation. Yeah, for whatever reason, this particular view doesn't show the amount of decay, but there was a lot of decay up high, and it could have been resorption. We had a conversation with one of the other docs who was observing the case. She had mentioned that she took a course that there's something called pre-eruption caries that are seen in kids.
Cool. That was cool.
Something I was unaware of. Neither here nor there. The tooth was infected, needed to come out. That explained the thickening of the membrane here. We also had a tear here, which we'll unpack. Is this thickening more likely to result in a tear? And how would we change our approach if the patient has this? I think that's something we can look at. You astutely identified preoperatively the artery that comes through the buccal wall of the maxillary sinus, measuring where it is in relation to where your window is going to go.
Yeah, it was really prominent on the left side, not quite as clear on the. Yeah, there it is. Not quite as clear on the intraoperative. Yeah. Not quite as clear on the right side.
So
one of the main problems I ran into was I was actively trying to avoid that site, and I opened my window on the left side a little closer to the crest of the bone than I'd like to. Even though I measured, I laid my flap, I took a bully gauge, and I specifically tried to measure approximately where I wanted to be to make sure I was really safe from that distance, but I ended up opening it too crustal. So we ended up intraoperatively, we had to expand that more coronally.
Yeah.
Yeah.
And I think in hindsight, the size of the window limited our ability to predictably lift this side of the patient. Yep. As we'll see in the post-treatment radiograph, we were able to do it, but it was a lot harder than it would have been had we had a big window. So in preparation for this meeting, well, of course I had to restart everything, but sinus lift, PICOs. I found a really cool pictogram on what a lateral window should look like. And it's this one right here. So the blue is the sinus. Here's the window. Because of the position of that artery, and I forget the exact name of that artery. It's the anastomosis of the PSA to the MSA, something like that. The point is, there's an artery in the cortical bone of the buccal aspect of the maxillary sinus. Because of that position, your window was hindered, and you actually had to go a little bit south here. But in an ideal situation where that is superior to where we were, this lateral window is nice and large so that we can really get in there and see the entirety of the sinus without having to rely on tactile feel or guessing where things are. So this window, this picture here is something I refer to often. Bigger is better, and if we watch Picos's videos, he does a really good job of really reflecting the flap. Using this picture here, can you speak to flap design and what you would have done differently with your flaps to create a better window? Would you have done a bigger flap, a smaller flap?
I think as far as flap design goes, generally when a patient has teeth, when they're dentate, this patient was a dentulous, obviously. So when they're dentate, it's common to make the incision in the mucosa itself, depending on where you are and in relation to the dentition, making it directly in the mucosa, making it like a semilunar incision and just really flapping that back. Because he was a dentulous on the right side, I opened the flap about at the crest of the ridge, which ended up becoming a major problem for me at the end because I had to open it up completely on the lingual to get that resorbable membrane in to close everything. On the left side, we had no issues like that because I brought my flap from the buccal through into the lingual and I flipped the whole thing back, which is a lot easier to close that.
Yeah.
But both are good sized.
We talk about the semilunar incision, and I think the semilunar incision probably better for small surgeries like apicoectomies. Watching Picos lay flaps, and I know this comes from him because in his videos you always see he's flapping a lot more than we think. So this is a really good picture of, he did a crestal incision, probably a palatally biased flap on the crest.
Can you show everybody exactly which one you're talking about? It's not clear.
You can't see this right here?
No.
Is that more clear?
There you go. Yep.
Yeah.
Nice.
Yeah, and this is actually from his website. Looks like he has a hands-on course, which we should look at. Moral of the story is better flap reflection, bigger window, more visibility, better control. And I like this picture where he laid the flap. The maxillary tuberosity, lifting up to that, to the cheekbone. There's nothing in this area with a full thickness flap that's going to get us in trouble. The problem areas are inside the cortical bone, which we have identified. Sometimes we have to intentionally go through that and then manage it by crushing the bone, topic for another day. But laying good flaps and seeing how far back he went. I think yours was like this.
Yeah.
And then you tried to reflect, and you were fighting the flap more than you should have, and fighting the mucosal flap as you're trying to manage the Schneiderian membrane inside the sinus. That's a lot going on. So bigger flaps are easier to manage. You just take your Minnesota and you reflect. You're not worried about visibility. So that would be something, in hindsight, that we could say could have been better. Bigger flap. As you identified, we're limited by the presence of this artery. This asymmetry to the maxillary sinuses has more to do with this. This is the slice right here. The patient was positioned in an odd angle in this pre-op CAT scan. You and I know that this bilaterally was more symmetrical than we thought, or more symmetrical than we can see here. Measuring that so that you get some insight on where to make your window was a good pre-op assessment. Anything else about pre-op assessment that we looked at?
This did not, especially in the anterior region where we ended up trying to do some temporary anchoring with mini implants. The bone, you can't appreciate how poor quality the bone is, because preoperatively I was like, oh, we've got space, we're going to get in 4-6 mini implants to help this guy stabilize temporarily after we finish the surgery today.
Yep.
It was not. It was terrible.
Yeah. you know, you and I are. Excuse me for a second. I got to sneeze. You
That was such a dad sneeze.
Oh yeah. 3 kids will do it to you. So you and I are always trying to kind of push the envelope with cool techniques, scouring the internet, reading literature, coming up with our own tools and techniques. And one of the things we're dabbling with is using mini implants to temporarily anchor dentures while other surgeries are healing, and that's what we intended to do here. And as you had identified, the bone quality was just not sufficient for placing of mini implants. And we could unpack that, but let's maybe do a separate video on maybe what we would have done differently there. But the goal was to get him palateless at the time of sinus surgery with some mini implant retention. And you got some in there, and it's working, but the question is how long will they retain based on the bone quality that's there.
It's not palateless either. He's got a palate.
He's got a palate, yeah. We decided not to remove it, and I think that was a good call. So coming back to the pre-op assessment, you know, I'll often look at the turbinates to try to see, you know, is this guy breathing well? You know, we do a lot of airway stuff, so we're often looking at the turbinates. But I want to make sure that the patient has a clean sinus, and if I see a lot of inflammation here, I may put the patient on a pre-op sinus triage kit, xylitol sprays, the clear spray, Neomed sinus rinses, Flonase. Maybe we work with the ENT to kind of augment that. Point being that if we're going to do major sinus lifts, we want to make sure that the patient has good nasal sinuses. This isn't bad, but typically what I'd look for is the turbinate touching the, I don't know what you would call that, the medial wall, the lateral wall, and the inferior wall. If the mucosa of the turbinates is touching, then you have blockage of airflow. You're more likely to have sinus issues. So if we can control that leading into the process, we're more likely to tilt the scales in our favor. This was a low risk situation. With that said, this was something that we looked at ahead of time. All right. Anything else on pre-op considerations, assessment? You know, are we worried if we take that tooth out that we're going to get a hole in the sinus? You and I unpacked that, and our conclusion was, how is a hole in the sinus any different? When we say a hole in the sinus, we need to know what we're saying. So let's take a step back. There's a hole in the cortical bone of the sinus, and then there's a hole in the cortical bone and the Schneiderian membrane. It's the Schneiderian membrane hole that we're really worried about. So if we could reflect the Schneiderian membrane here, take the tooth out, and then there's a hole in the bone, there's nothing bad about that.
You wouldn't call that an oral antral communication?
Well,
it's an interesting thought because the Schneiderian membrane's still intact, and then you cover it, but I'm sure it still is an OAC.
Yeah, if I had to say, an OAC would be defined as a Schneiderian membrane perforation.
Yeah.
Because it's that communication of the air and potential bacteria that causes a problem, not a hole in the sinus. So you and I have done like a lot of Densa burrs where we intentionally drill a hole in the cortical bone, but we're hoping not to create a hole in the Schneiderian membrane. Is that an OAC? Not really.
Not if you plug it with an implant, right?
Well, you're plugging the hole. Well, it's the Schneiderian membrane perforation that causes a problem. If you did a hole in the sinus in the cortical plate, that'll heal uneventfully. And we know that because how many teeth have we removed where there was a hole in the sinus, but then we did the Valsalva maneuver where you have the patient pinch their nose and blow to create positive pressure, and there's no bubbling. Is that an OAC? No. Those will heal on their own. It's the hole in the Schneiderian membrane that's the problem. So obviously we wanted to not have a hole in the sinus membrane as we did the sinus lift, but we have to know how to repair them on the fly. We should never do a sinus lift unless we know how to repair small, medium, and large perforations during the sinus lift, and PICOS goes over that. Knowing this was going to be a big case, we knew that we were going into it with PRF. So PRF, for those listening, platelet-rich fibrin, allows us to create biological membranes using the patient's own blood and concentrated growth hormones that allow us to repair membranes very predictably if there is a perforation.
I mean, it's not just membranes. We use PRF in all aspects of surgery to improve wound healing.
Right.
And we have certified phlebotomists who do our draws for us, which is wonderful.
Yep. Yeah, so Ashley was able to get 8 tubes. So we had plenty of membranes to use for a variety of different reasons. In hindsight, we could have mixed, and here's our grafts. We could have mixed a bone graft with the PRF. Before we start assessing the left and right here, if we mix the graft with PRF, so we take the PRF membranes and we cut them up into little pieces and mix it with the graft, what are we doing? What would be the goal there?
In my mind, we're bringing the natural immunity of the body into the graft. So
Correct.
We're filling it with all of our own antibodies and creating a nice barrier for resistance.
What's special about LPRF?
The leukocyte-rich, platelet-rich fibrin?
Yep. So that's where that immunity comes from, is the specific tubes that we use, the centrifuge. Those are all very specific to create leukocyte concentrated PRF. Not all of the techniques and methodologies have that benefit. One of the important things that we have to know is that mixing PRF in here does nothing to the bone healing. There's nothing in PRF that increases conductivity of the bone or induction of the bone healing. It's purely a matter of decreasing chance for infection and immunity. PRF, on the other hand, when it comes to soft tissue healing, is basically super fertilizer. And we've seen cases where, say, a socket preservation that we use with PRF, you'll have soft tissue healing in days, not weeks or months. So the point is, PRF is a soft tissue accelerator, soft tissue healing accelerator, not a bone accelerator. But if we were to mix it with bone, we have to know what we're doing. We're just decreasing the chance for infection. We didn't do that here. I ended up using, because I was off to the side mixing the bone for you while you were doing the procedure, I mixed it with azithromycin and amoxicillin. One might say maybe I should use Augmentin up in the sinus because of the beta-lactamase enzymes that are associated with the bacteria in the sinus. It's not routinely done where antibiotics are mixed with grafts, but there's a really good article that James Rakowski had done years ago, and it was in a textbook. I don't know what the textbook is, but he sent me the chapter that he had written for the book, so I have a copy of it, and it's specifically on antibiotics in bone grafting, talking about which antibiotics you can mix with bone grafts. And the takeaway message is there are many antibiotics that are actually cytotoxic to the healing of the bone graft. So we can't just willy-nilly throw every antibiotic that we want into the graft itself. There are vancomycin, I think. I'm sorry, lincomycin is what he recommended. James Rakowski being the editor of the Journal of Oral Implantology. He's also a pharmacist, I believe.
PharmD, yeah.
Yeah, he's a PharmD, so he's a smart guy, very good dentist, teaches all around the world, and he specializes his efforts in the world of PRF and bone grafting. So, moral of the story is, if we want, there are some antibiotics that we can mix with the bone graft, whether we think there's going to be the need or not. The reason I chose it in this patient, he is a diabetic with an A1C around 7. So I wanted to make sure I was okay sacrificing the healing capacity through the potential cytotoxicity of the antibiotics with the profound effect of protecting a patient who's at higher risk for infection. So
Yeah.
do we routinely place antibiotics in the graft? No. Picos doesn't do it. At least none of his videos he talks about it. I think he touches on it a few times, but he doesn't routinely do it. With that said, I do think he puts PRF fragments in there, and that's his antibiotic approach. As far as kind of what we did with the bone, we used, what did we use for bone graft here?
Oh, sorry, I'm losing you.
Can you hear me
I think you
okay?
were asking what. Yep, there you are. So we used the 70-30 cortical cancellous blend from Jannate BioHorizons.
Yeah. So why would we use 70-30 instead of maybe a pure allograft, demineralized, or
I mean, Sam Lee, who I recently saw, was just such an advocate of the more cortical, the better. And he gives these patients, I think he said at least, I know the minimum for him is a year, up to 18 months to let that cortical bone fully turn over and do what we need it to do. But in this case, we use 70 cortical because we need more cortical. If it was a 50-50 mixture, we would lose so much of that cancellous bone right away. We'd lose a large volume of our graft.
right?
So the more the better.
Yep.
And the longer to heal, the better. You want to let it set for a long time, at least 9 months to a year.
Definitely. Yeah, especially the left side where the graft is this big. This is a 9 to 12 month healing. This we could probably say more 6 to 9. But you're right in the fact that the more cortical the bone, the better the space maintenance. But we also have to admit that might never turn over. So cortical bone does turn over more slowly, but there's a lot of literature out there to support that you might not get 100% turnover. But the point is we need enough conversion to vital bone in a properly space maintained graft so that we eventually get enough vital bone to place implants. And the perfect mixture, I think you and I have settled on 70-30. There are a lot of 50-50s out there. Then there's, using xenografts like BioOS. That was a very favorable approach for many years. Using pure xenograft has been shown to just be too cortical, and you don't get enough vital bone creation over time. So we're settled on 70-30. We're happy where we're at. We've done many of these cases where we've gotten pretty good space maintenance. With that said, we kind of want to overbuild, knowing that we're going to get some volume consolidation when using cancellous or demineralized bone. So we could continue the conversation about selecting bone. 70-30 is what we used. That's in line with what Picos uses. I think we're going to get a good result here. So you started on the right side. You made a window, and we can see. Let's see if we can see the window right there.
Yep.
So, in hindsight, would you have made that bigger?
Oh yeah.
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 Can we see the artery here?
I might say I can hallucinate something on the right side. Right. I think you can see the indentation of it.
Like right there?
No, I think it's way up high. No, maybe not. I told you I was hallucinating.
Well, the good thing is when they're small, they're not concerning. It's when they're large that they're more likely to have, especially if they have compromised clotting, then it's something you want to avoid. So if you can't see it, the fact you go through it is probably of little consequence. So I think here you could safely have said, maybe that's it there, although that's pretty low, and I forget the average height there. There's a degree of variability in where it shows up, but I think if it's that small, you can confidently get in there and just manage the bleeding, and that patient will probably clot pretty well. One of the beautiful things is if that was it and you clipped it, what great bleeding you'll have in the site. And when we put bone in, we want a lot of blood. We want the clot. The clot is where the magic happens. It's not the bone graft. The bone graft is simply a space holder that allows the clot to do its magic through inducing angiogenesis. So we want to have a really good blood clot in that area. So there are times when accessing that bleeding is actually advantageous. With that said, knowing how to manage the bleeding when it happens, knowing how to assess where it is a very important part of this. So you made the window, you reflected. Did you feel this right here? So before you got in there, we had a conversation about properly lifting the Schneiderian membrane. And one of the things I've noticed is this floor right here often feels flat. And I have a hard time appreciating when I'm on the medial wall.
Yeah.
It just,
And I mean, that was the part of the most challenging part of the process, is getting that tactile sensation of the membrane lifting. I mean, once you get that initial lift off and then just really slowly advancing, the whole time you think you've torn it, or you're in the beginning, you feel like you're tearing it or you're doing something wrong. But once you lift enough, I mean, it is, you, for this patient who already naturally had slightly thicker Schneiderian membranes, especially based on the area that he lives in, there's a large mill in the town. So, you know, naturally over time, it's for his membrane, it's almost like he's a smoker, just thicker and tighter. But you could really feel it by the end of the procedure, how the pushback that it would give you and the bounce to it.
right. Being able to see it, I think is why we want to have a bigger window. So when you have that thought, did I tear? Did I not tear?
Yeah, you could just look.
You can look.
You could just look.
Yeah. So when you started advancing medially, feeling this little inflection point is what I use to tell me, am I at the right spot? So once I feel that, that's typically around the area where I want to fill up to. So you can see here we did a good job of that. Here, I know we felt it, but I think the volume of bone you put in was just insufficient. Now, you might have felt compaction, so you might have felt like you were actually getting bone in there, but the lesson is when you start to place bone, you actually want to place it up here.
Yeah.
It's hard to do. Now, you had made a comment that Samuel Lee, who's a periodontist who teaches on all kinds of surgical things, had mentioned he only puts, what, 2 cc's in?
Like 2 to 3, yeah, is his max. Maybe he specifically said 2.5. Don't quote me on that, anybody. But yeah.
You know, this was like 4 to 5. This side is a little bit more like 2.
Conservative, yeah.
Yeah. Let's ask the question, was this enough? Let's see here. Yeah, you know, we'll be able to place 10 millimeter implants in there without a problem. But that was on the edge of not enough.
Well, especially if we get resorption of the graft, it'll be less than ideal.
Sure. If you can, I'd love for whatever you can get from Lee as far as literature on why he recommended that. I think the reason he recommended less is better is because the amount of angiogenesis that needs to happen to actually convert this into a vital graft, less is more. With that said, I don't know, just watching Picos do his stuff, it's amazing how big his grafts are. And I think this little inflection point right here is the goal. I can't say whether or not 5 cc's is the right number. That's just what I was taught. But 20 millimeters high, I like this one better.
Yeah.
The whole point of debriefing here is to have this conversation versus just doing the procedure and not really knowing, not asking the question, did I put enough or did I put too much? And I think the answer probably is somewhere in between the two.
Well, something that you and I talk about all the time, Nick, is reflecting on your growth in the profession. So if we weren't doing a debriefing, I would have looked at the CBCT and been like, yeah, it was good. Like right side could have been better. Left side, we got a lot of graft. But spending the time to really talk about it and dive in, I mean, there's a lot of value in that.
Sure.
The after action report.
Yeah. As I shared with you, the universe threw down on me about a month ago the power of debriefing. That's kind of why we're having this conversation, for the betterment of anybody who wants to listen to what we have to say.
Who did you go see fly? Was it the Blue Angels?
The Blue Angels, yeah. I didn't go see them. It was a
There's a,
Netflix documentary on it, and they emphasize the power of debriefing. I have a friend who's a fighter pilot. He showed up a week later. It came up organically in conversation that they would routinely have 17-hour debriefs sometimes when they would do sorties in Afghanistan during the war. And what he would say is, we would have a 17-hour debrief on something where nothing went wrong.
that's incredible. I mean, just think of the value of that.
Yeah.
That's crazy.
He said at hour 16 it started to get a little too much, but for him to say 16 hours of debriefing on a mission that didn't go wrong, I think we can glean something from that, and I think that's what we're trying to do here. Yeah. So this side went pretty uneventfully. I think you said there was a small tear here. Ultimately, we put PRF on the roof,
and that's what we're seeing. That's what you're seeing in this radiograph. You can see that's the layer PRF in the cross-linked collagen membrane. Yeah. On the left side, we did have a big tear, so we used a lot more material to make sure that it was totally sealed.
So let's say we didn't have a tear. We have 8 huge PRF membranes.
Still using them.
Yeah. Might as well put it up there. So whether we have a tear or not.
I like to use it to lift. I like to put it down as once I've got enough lift, I like to put that in, put the cross-linked collagen membrane in, cut it in 4 corners so that it folds appropriately as you seed it through the sinus window.
Yep.
I like to use that to help me with the lift. That's recommended by Dr. Picos and Dr. Lee as well.
So if we have a perforation, do we want to put PRF first, or in this case we use Memlock, which is cross-linked collagen membrane, very slow resorbing. You and I had a kind of a game time conversation about what to put first, what to put second. Do you want to shed any light on which?
I like the idea of the PRF first.
Yep.
PRF first, and because that's going to resorb quickly, but it's also got all the leukocytes and all the other kind of antimicrobial innate properties that we want, and then covering that with the cross-linked collagen membrane, which it's less sticky, the cross-linked collagen membrane. Yep. So it's a little easier to manipulate inside the sinus.
Yep.
As opposed to the LPRF. And then closing the window, it's the opposite order. You put the resorbable membrane down first and cover that with PRF.
Yep. Yeah, the way I think about it is the PRF should face the tissue, whether it's the mucosa on the outside, just like you said, it's reverse. But you think of the Schneiderian membrane as a tissue. So if you have a perforation and that membrane is what's closing that hole, the Schneiderian membrane is a form of tissue, so it's going to heal a lot faster with the PRF being the entity that's right there. And then really the only reason we have the Memlock in there is to prevent that tissue from invaginating into the graft. So you want the Memlock to be touching bone, PRF touching tissue. So what we did is PRF, Memlock, PRF.
Yeah.
Yeah. So that side went pretty well. I think you were fighting, kind of tucking the membrane under here. In hindsight, as I was watching you do it, easy for me to play Monday morning quarterback as I was watching you do it. I don't think I would have done anything differently, but in hindsight, the membrane would have been a lot easier had you had the flap come all the way up here and then maybe down here. But that membrane has to be maybe 3 millimeters in all directions away from the bony window, and it should be stabilized. So Mike Picos talks about tacking the membrane, so actually having this membrane come up and then fold over right here, and he tacks that, and then he tacks the membrane as it sits on the outside. And the concept is the movement of the mucosa after you close all of this pull from the muscles up here when the patient's masticating and smiling can destabilize the graft on the inside simply from movement of the graft right here. So in hindsight, I think if we had used tacks here, that tacks will stabilize it. Picos has several studies that he refers to that says that's advantageous. So the tacks are more for the health of the graft and not so much for stabilization of the membrane, although that's what you're doing. The goal is to prevent movement of the graft.
Yeah.
So, You and I have struggled with tax, as I think a lot of providers do. We've tried the auto tax system. We've got the ACE surgical kit. I think you and I getting really good at tax. Maybe we get some bone and we play around with it on a dog bone or something like that to try to get a better handle on how to predictably place tax, because it's no
I
secret.
swear to God, they go in and then they come right back out.
Right.
Like, doot, doot.
Yeah.
You know, come on, man, stay.
But I think that would be a good thing for us to move forward. And one of the things I wanted to say is, like, you and I are general dentists talking about something highly surgical. You and I are both completed Maxi courses. You are a fellow in the American Academy of Implant Dentistry. I'm a master in the associate field. Well, yeah. Are we experts? No. Michael Picos would be the expert. But have we done enough of this to shed some light on what could be better? Yes.
Yeah.
So when we say things like we struggle with tax, these are just the realities of complicated dentistry. I know plenty of surgeons who don't use tax because they couldn't get used to them either. With that said, I think we need to figure out ways how to get there. So the right side, I'd call that a good graft. I think more volume.
Let's give it a B-, or how the kids would say, maybe a, I don't know if a 4 or a 2 is the right score.
Yeah. No.
Let's call it a 3. 3 plus, maybe.
Yep. On this side here, we had a massive tear, probably due to the fact, you got this tooth out. It's very possible that when that tooth came out, a tear happened. The tear was big enough that I think most inexperienced surgeons would have just closed it up and prayed. But Picos talks a lot about there is no tear that you can't repair on the fly with PRF and a good Memlock membrane.
I was ready to close it up. I was like, oh man, that's too big. Oh no, we'll come back in a year. Oh yeah.
Yeah, and I think
was a big tear.
My confidence came from Picos's whole series on how to manage tears intraoperatively. If you have, here we can see the PRF. We packed a lot in there, so we were obviously scared. Here's the Schneiderian membrane. Here's all the PRF because we had a lot, so we used a lot. Look at that zone of protection with the PRF. And then we also had relatively good confinement of the graft. So none of the graft made its way through and made its way into the superior compartment of the sinus, giving us a strong sense that we're going to be more than fine. The osteomeatal complex is up here, so we didn't block that. So I think we can be rather confident that it's going to heal very well. One might say, what is this here? That's just a clot, a blood clot. If that is still there in 9 months, 12 months, that might be a area of concern. But where we know, yeah, sweetie pie, we're almost done. Yeah, you want to look at sinus lifts?
My sweetie pies are screaming downstairs. I hope no one in the video can hear that.
Well, I think we've covered quite a bit here. We've confirmed that the grafts were contained through the very flatness appearance of this. None of the graft extruded into the PRF, and none of the graft extruded into the sinus where we're risking having blockage of the osteomeatal complex. So maybe we'll do a debrief in 6 months when we do the post-op CT and we get a sense of how much healing has happened, and we'll talk about what we're going to do with the implants.
Sounds like a great plan.
Yeah. All right, bud. Good debrief on a successful sortie. Hope you have a good day.
I think we should call all surgery going forward sorties.
Well,
gonna have a sortie this afternoon. Can't wait.
Yes. All right. Let's go pay attention to the kids, and we'll talk to you soon.
All right. Later.
Later.